Good morning. I'm happy to join this Right Heart Intervention Summit. Unfortunately, I have committed for another meeting in another part of the world, and so I'm not able to be physically present, but I'm very happy to join. We will be discussing on particularly pulmonary valve implantation in different right ventricular outflow tract subsets. If we see the different types of RVOT morphologies, the most traditional subset is conduits. Most of the conduits will be stenosed conduits. They may be either homographed or it may be xenographed like contagram, or it may be handmade pericardial conduits. Rarely there can be conduits that are not stenotic but severely regurgitant. So they are non-stenotic regurgitant conduits. The larger subset, almost about 3/4 of the patients, will have native right ventricular outflow tract, which is post-transandler patch. The easier ones to deal with in native transandler patch repair is the tubular RVOT. The more challenging ones are the pyramidal RVOT. Pyramidal RVOT refers to distal main pulmonary artery being narrower and the proximal main pulmonary artery at the right ventricular pulmonary artery junction being very broad. Then comes the hourglass narrowing, wherein the narrowing is in the region of ventricular-arterial junction. There is a unique subset of native RVOT wherein the landing zone may be very close to the coronaries and coronaries may get it. The last subset will be bioprosthetic valves implanted in the pulmonary position, which are degenerated. So let us deal with it step by step. The first subset is stenotic conduits, which is the commonest. It can be in the setting of tetralogy of Fallot, where a conduit has been placed either for TOF pulmonary atresia or TOF with anomalous coronaries. It can be for TOF with absent pulmonary valve. It can be any of the rationally repairs for DORV or DTGA. It can be sometimes initially a transandler patch repair of the tetralogy and subsequently a surgical pulmonary valve implantation with a homographed conduit. Rarely it can be an aortic valve disease where Ross procedure has been done. An example of a stenotic minimally calcified conduit. A 19-year-old child who has tetralogy absent pulmonary valve syndrome, it operated in infancy. So this is the stenosed conduit. So this is an 18-year-old pulmonary homograft with very minimal calcification. The gradient is almost 137 millimeters of mercury. So you put a pre-stent in. So these are two pre-stents of Andra XL dilated to 22 millimeter. We are not using a covered stent because an 18 millimeter very minimally calcified homograft is just dilated to 22 millimeter. Final gradient significantly reduces. And then a 23 millimeter MyVal is implanted within this. Now this follow-up is more than 5 years. The valve is functioning very well. So stenotic minimally calcified conduit, a bare stent followed by valve implantation. So when is a covered stent mandatory? It is mandatory if it is aortic homograft conduit. In calcified pulmonary homograft conduit, the patient is significantly of older age group, and if you are oversizing the conduit by more than 4 millimeters. In uncovered stents may sometimes be acceptable if it is a contagram or a handmade bowing pericardial conduit. Non-calcified pulmonary homografts, when you are not oversizing by more than 4 millimeters, and in non-stenotic conduits. An example where a covered stent is being used, this is a Ross procedure. The Ross procedure, a 56-year-old person with bicuspid aortic valve stenosis, Ross surgery was done quite long ago, 20 years ago. It was a 21 millimeter pulmonary homograft. Again, there is minimal calcification, but the patient is old. So it is being stented with covered Andra XL as well as CP stent, dilated to 24 millimeter. After that, you are landing a 24.5 millimeter MyVal. So a 21 millimeter homograft, a pulmonary homograft with some calcification in an elderly person. After a covered stent, valve gets implanted. Non-stenotic large conduits. Rarely, conduits sometimes may not be stenotic at all. They'll be very large and they'll be completely be regurgitated. A 25-year-old lady post rationally for PORB at 2 years of age and subsequently gets a 25 millimeter pulmonary homograph at 10 years of age. So this 15 years later, this pulmonary homograph is not stenosed. It's just severely regurgitated with very large right ventricular volumes and very significantly increased pulmonary regurgitation fraction. So in this subset, we are pre-stenting the 25 millimeter conduit with a bare stent. This is a 26 millimeter bib balloon with a EV3 intrastent max stent. So a 26 millimeter bib balloon stent was deployed. If you see, the conduit is so much dilated that the proximal end of the stent is not actually approximating against the conduit. So there is a free step here. So this is in a epicranial projection. So what you have to do is, you have to optimize this conduit by putting in balloons such as the Coda balloon or the Medtronic Reliant balloon, which flares out this entire stent. Once it is flared, you can see that the proximal end is fully flared. Then it allows the valve to pass through. Otherwise, the protruding edges of the stent may not allow the valve to pass through. So once the flared end is there, the valve will move into the stent. This is a 26 millimeter MyVal through a navigator delivery system on an underpist wire and is getting deployed. So this is the deployment and post-deployment. So this is an example of a non-stenotic regurgitant conduit. This is post-valve. Valve function is good and the coronary is also unaffected. So in all these conduits, what exactly is the advantage compared to a Sapien S3 valve? It's available in larger sizes, which means XL sizes, 30.5 and 32 millimeter are available. And currently we even have an access to 35 millimeter valve. In fact, the 32 millimeter valve, if you overinflate, you can even reach about 33 ml or so, millimeter or so. And there are multiple intermediate sizes. This may be the advantages over a Sapien S3. What happens if there is an extremely large conduit? This is a 35-year-old male who had a Ross procedure initially. Subsequently, the autograft failed. So he gets a Bental procedure. So this is a Bental aortic mechanical valve. And he gets a third surgery where the previous pulmonary homograph was changed into a handmade 28 millimeter bovine pericardial tube. This pericardial tube progressively degenerates and leads to severe pulmonary regurgitation with massively dilated right ventricle. So this hugely large 28 millimeter handmade bovine pericardial conduit now needs a valve. So when you are doing the dilatation, there is a severe free pulmonary regurgitation with a massively dilated right ventricular outflow tract. It's a tubular conduit, but it is markedly dilated. And if you look at the dimensions, it's almost 28 millimeters. Maybe possible with a 32 millimeter MyVal because it's very expansive. So we are doing a balloon testing. On balloon testing with a 30 millimeter ZMED balloon, the waist measures, there is no waist, but the measurements that we are getting is close to 28 to 29 millimeters. So here the 29 millimeter, but there is no waist. So we decided to go for the 32 millimeter valve with 5 ml extra volume. At this size, there are no pre-stents that are available. So it's a direct valvulation. So the valve is positioned and it is fully deployed to 32 millimeter with additional 5 ml volume. At the end of it, when you try to measure it, the valve is almost 32 millimeter, both on an AP projection as well as in the RVO projection. Such large sizes are not feasible with S3, and hence there is an advantage for the Indian MyVal. Coming to the most difficult subset, it is the native RVOT. The most common type of native RVOT is pyramidal RVOT, which almost accounts for about 40 to 45% and is largely considered as not suitable for percutaneous pulmonary valve implantation. Then comes the tubular right ventricular outflow tract, which is type 2. Then comes the reverse pyramidal, hourglass and reverse hourglass. Now, this pyramidal outflow tract is a challenging anatomy. Even in tubular RVOT, sometimes it can be very expansive. So that makes it challenging. Let us talk about pyramidal outflow tract. we have to find out whether the pyramidal outflow tract is stenotic or non-stenotic. And if there is stenosis, is the branch pulmonary artery origin also stenosed or only the distal main pulmonary artery is stenosed? If the branch PA is narrow, is the branch PA asymmetric, which means one of the pulmonary artery is minimally stenosed, the other is tightly stenosed. Is the distal main pulmonary artery the only lesion to be stented? I'm going to show some 2-3 examples of this pyramidal outflow tract. CT scan showing a large proximal RVOT, narrow distal RVOT. RPA origin as well as LPA origin both are having some narrowing. So this is a virtual reality. On virtual reality we are finding that there is a distal RVOT narrowing. So the plan will be to try to interrogate what is the gradient. So there is 30 millimeter in the right pulmonary artery, 25 in the left pulmonary artery, 60 at the level of distal main pulmonary artery in this segment. And then proximal RV is 72 millimeters of mercury. So initial balloon dilatation is done by two femoral sheets, two 12-French sheets, two 22 millimeter balloons simultaneously inflated, and both the pulmonary arteries are stretched at the same time. This results in branch pulmonary artery origin gradient to be eliminated. And now there is only a narrowing at the distal main pulmonary artery. And so we need to have a stent only in the distal main pulmonary artery. So we use what is called as the 2-wire single stent strategy. So you park one wire in the left, one wire in the right, take a balloon and a coronary guide catheter together and mount a stent on it. So this is a 42 millimeter Zephyr XXL on a 30 millimeter Z-Med balloon plus a guide catheter. Everything goes through a 24 French long hook sheet. So we are trying to push this stent against the carina of the two pulmonary arteries so that the two wires will prevent the stent from going distal beyond the most distal part of the main pulmonary. So at this point, you inflate the balloon and deploy the stent. So the stent gets deployed at the most distal part of the main pulmonary artery. So the last part of the main pulmonary artery now is stented. Already we have dilated the origins of the right and left pulmonary artery with a large 22 millimeter balloon. So now into this landing zone, a 32 millimeter MyVal is deployed. And at the end of the MyVal deployment, within this distal main pulmonary artery stent, we are having unobstructed pulmonary blood flow, competent valve, and coronaries are not obstructed. So this is an example where distal MPA alone is stented without any branch pulmonary artery stent. What if there is severe branch pulmonary artery stent? A 30-year-old lady with a transcendent patch at 4 years of age, severe LV origin stenosis, significant dilated right ventricle. Again, a pyramidal outflow tract with origin of the LPA being narrow. So what we do is stenting from the LPA towards the main pulmonary. So this is a stent that runs from the middle of the LPA to the middle of the main pulmonary. The full stent is deployed across the left pulmonary origin. Then you cross the side strut and you enter into the right pulmonary artery and dilate the right pulmonary artery. This is followed by flaring of the proximal of a part of the stent by a coda balloon or a reliant balloon so that the stent edges are approximated to the right ventricular outflow tract, and this is followed by angiographic measurements. So now the stent is completely opposed to the RVOT. It's running from the left pulmonary artery to the main pulmonary artery with side strut dilated towards the right, and here you take the measurements. Based on the measurements, then choose the valve. Since the valve is, after the valve is deployed, the right pulmonary artery origin is appearing little narrow. So cross through the struts of the right pulmonary artery and you find that the RPA origin through the struts of the valve is not having adequate orifice. So then position a small Cook formula stent of around 10 millimeter. Deploy most of the stent distally and keep only the proximal small strut proximally, and then get a full dilation. So in this patient of pyramidal RVOT, initial stent is from the left pulmonary artery towards the main pulmonary artery, followed by the valve. That's followed by RPA stenting. Another example of a pyramidal outflow tract where sort of similar approach. RPA is much more larger here. So here, a tight LPA origin stenosis. Same strategy. We are deploying a stent from the left pulmonary artery towards the main pulmonary artery. But remember here the RPA is slightly larger. So the next step was dilating the side strut of the RPA, flaring out the proximal edges with the reliant balloon, and subsequently you get the valve implanted. Once this valve is implanted here, the RPA, since the RPA was relatively larger and the RPA had been dilated, here there is not too much of restriction to the RPA flow. So here in this strategy, it is left pulmonary to main pulmonary stent followed by RPA dilatation followed by valve. The last subset is pyramidal outflow tract with no stenosis at all. So this is the RPA and LPA being very large, but the distal main pulmonary artery is little smaller. It is no gradient, but it is small. If you look at the proximal part of the right ventricular outflow tract, it's much more large. So in these places, you have to precisely land the stent exactly at that landing zone. So an RVOT angiogram in epicranial view as well as RAO cranial view shows that distal main pulmonary artery narrow. Once the narrowed site is identified, the balloon interrogation is done with a 30 millimeter cement balloon, and you find that there is a complete occlusion. So this is followed by a 32 millimeter valve, which is deployed, partly open the valve, and then do a check angiogram. And then finally fully deploy the valve, and then do the final angiogram. So there are 4 examples of pyramidal outflow tract that I showed. Only distal main pulmonary artery stenosis, put a localized distal MPA stent. If one branch PA stenosis is also there along with MPA, then stent from one of the branch pulmonary artery towards the MPA. If both the PAs are narrow, then stent from one of the branch PA towards the main pulmonary artery, put the valve, and then stent the other pulmonary artery. And if there is no stenosis at all, precisely land exactly at the distal part of the main pulmonary artery. So these are 4 strategies for pyramidal outflow. In native tubular RVOT, if the tubular RVOT is very large and expansive and more calcified, sometimes you may have to pre-stent. See this example of a 30-year-old person with post-transcatheter patch, autologous pericardial patch. But there are quite a lot of calcification. See that there is totally calcified, even circumferential calcification. So here what you do, if you don't want to directly put in the valve, so you pre-stent it with a 28 millimeter balloon over an Andra XXL stent. So this is a pre-stenting that has been done. Following the pre-stent, then put in the valve. So this is the valve being deployed. Coronary is checked in final position. Here you can find that actually there is a sort of a ventricular tachycardia going on when the stent is being deployed. Very irritable heart, prone for ventricular tachycardia. There are some operators who always do a RVOT pacing. They rarely do an RVOT pacing because right ventricular outflow tracts, since they're scarred outflow tracts, they don't move much. So quite often I don't adopt rapid pacing as a strategy. So this is an example of a RVOT stenting followed by a pulmonary valve implantation. This irritable outflow tract, the ventricular tachycardia settled once the catheters are pulled out. Last subset is outflow tract where coronary is extremely close. I'm going to show some examples. This is a single lung ICR. So the patient has got only right pulmonary artery. And the main pulmonary artery to right pulmonary artery, that junction is the narrowest portion. So this is the potential site for a landing zone. However, when we are positioning a balloon and checking, here the LMCA is getting compressed. So if you are landing the valve in the MPA RPA junction, which is little narrow, the patient is going to have a coronary compression. So now what you do is you move proximally and try to find out whether this ventricle can be an option. So this is a transcender patch, the proximal end of the transcender patch of the ventricle. So here it is very dynamic. But the dynamic area when we are interrogating with a balloon, a 30 millimeter balloon, we are finding that the coronary is not getting compressed and the balloon is not being squeezed. But it is very dynamic. So you go for a 32 millimeter valve. On this 30 millimeter balloon test was positive. So we are taking a 32 millimeter valve and deploying exactly in the region of the outflow tract. So here what we are doing is, this is the valve being positioned, partly expanded valve, do a check angiogram. The check angiogram is looking fine, so fully expand the valve and get the valve completely across the landing zone. So this was an example of a coronary that was getting compressed if the valve was positioned distally. So we moved the valve proximally and now it is not getting compressed. This is possible because the valve has got a very small profile. The fully expanded length of the valve is only 21 to 23 millimeters. So in this example of single lung ICR, the valve has been positioned proximal to the coronary so that it's not getting compressed. Valve function is also good. An example of a hourglass right ventricular outflow tract where the left anterior descending coronary artery exactly courses below that hourglass region. This is an example of a hourglass right ventricular outflow tract in RVO projection as well as in lateral projection. And if you look at the coronaries, the left anterior descending coronary is just crossing at that region. However, with the 30 millimeter Zemet balloon in interrogation, there is no coronary compression. Since we are choosing a 32 millimeter valve, 2 millimeter larger, we are positioning the valve a little proximally. We are identifying the coronary, moving this valve a little bit more proximal so that it is not very close to the left anterior descending, and then expanding the valve. And as you are expanding the valve, you are checking that the coronary artery is actually a little distal to the place where you have landed the valve. So we have to have the coronary checks that are being performed as we are positioning the valve in order to avoid a potential coronary compression. This particular patient, in addition, had an atrial septal defect, needed an AST device closure. A more complex coronary abnormality is, this is an anomalous coronary. The left coronary artery is a single coronary. The right is given from the left and it is coursing interarterially. It is between the aorta and the pulmonary artery. This right coronary artery that is arising and coursing interarterial is in close relation to the place where we have to have the landing zone. So there is a right pulmonary artery narrowing. So this is an RP artery origin narrowing, and here is the place where we have to place the stent, and the right coronary artery is in close proximity to that area. So how do we address it? So initially we are doing the coronary angiogram. We are parking a guide wire in the right coronary artery and putting a guide liner into the right coronary artery. And then doing the balloon interrogation of the proximal part of the outflow tract. When we are putting a 30 millimeter balloon in the proximal part of the RVOT, this coronary is not getting compressed. So the proximal area, if you are landing a valve, you are safe. What about the distal RPA origin? When the balloon is moved into the distal RPA, we are finding a significant waste in the RPA origin. And at this place, the RPA origin, the right coronary artery is getting partly compressed. So we cannot use a 30 millimeter in the distal RVOT. So what we are doing here is deploying an RPA stent with 22 millimeter so that the stent is much smaller, and we dilate the side strut of the left pulmonary artery, following which we now try to land the valve in the most proximal portion. So this is the coronary that is being checked. This coronary is now unobstructed because we have expanded only to 22 millimeter, and we are now dilating the side strut with a large 16 millimeter balloon. Once that is done, the next step is landing the valve in the most proximal portion so that it is proximal to the coronary. We are having the guideliner catheter in the right coronary artery, and we are confirming that we are deploying the stent proximal to the anomalous right coronary artery. So now the right coronary artery is not obstructed. Such a valve positioning is possible in MyVal because the valve is little shorter. Even the largest valve measures only 23 to 24 millimeters. Coming to the last subset, bioprosthetic valves. Some valves can be fractured like Edwards Magna, Magna is Perimount. Some cannot be fractured like a Hancock. Some can be only remodeled. That means they can only be stretched. An example of a perimount that is being broken. So this is an example of a perimount that is getting fractured. You can see the sudden movement of the perimount valve and it is being fractured. This fracture will be associated with fall in the pressure in the inflator also. Post dilatation, you can use a larger MyVal into the previous bioprosthetic valve. So the valves that can be fractured are the Biocar Epic Supra, Magna is. The valves that can only be remodeled are the trifecta, Carpentier Edwards standard. The valve that can be not be fractured or remodeled is typically Hancock. MyVal Palmo is a distinct design where completely the valve is covered with a fabric so that it almost becomes like a conduit at the end of the implantation. After the CT shows a tubular outflow tract with a landing zone of around 27 millimeter, balloon interrogation is done with a 28 millimeter Z-med balloon and it shows that there is no significant residual flow. So this is a 29 millimeter pulmo valve being positioned and it is expanded. Again, there is no rapid pacing. And after the expansion, in fact, it's a slow inflation so that you don't get movement. And then this is the pulmo valve is actually an octacar design. And this balloon is called as the navigator inception. So that the dots will be asymmetrically be placed. Then check the valve position, check the coronaries. To summarize, balloon expandable valve with wide size range up to 32 millimeter are available with MyVal with intermediate sizes. So they are useful in stenotic conduit, non-stenotic conduit, very large conduit. You can use it in native RVOT, even in the pyramidal outflow tract where valve implantation is considered to be challenging, and even in those with branch pulmonary artery stenosis. People who are having risk of coronary compression, we can place this low profile valve either proximally or distally in relation to the coronary, thereby achieving a successful valve implantation. Thank you very much for your attention. Thank you.